Good evening, everyone. My topic for today's discussion is anti-hyperlipidemic drugs. This is hypolipidemic drugs, and today's session I will discuss these drugs. Now, hypolipidemic drugs or anti-hyperlipidemic agents are the agents which increase the HDL level. That is, high density lipoprotein levels are increased, and low density lipoprotein levels and very low density lipoprotein levels are decreased. And these are used for high levels of fats and such as cholesterol in the blood, hyperlipidemia. These are also known as lipid lowering drugs. Now, first of all, I will discuss with you the lipid transport and metabolism. And lipid transport and metabolism, it occurs in two main steps or two main types of lipid transport is there. First is in the endogenous system and second is exogenous system. In the endogenous system, the lipids are synthesized endogenously in the liver, and in the exogenous system, the lipids are ingested from the intestine and they are processed in the intestine. Now, this is how the lipid metabolism and lipid transport takes place. The person takes the dietary fat in the intestine. From the intestine, the cholesterol is absorbed in the form of chylomicron. On the chylomicron, the lipoprotein lipase enzyme X, which disintegrates the chylomicron into fatty acids and chylomicron remnants. And these chylomicron remnants get converted to IDL, that is intermediate density lipoproteins, and again taken up by the cholesterol. And these fatty acids which are formed, these are taken up by the body cells and assembled into triglycerides. That is, body cells like muscles and adipose tissue, these will be assembled as triglycerides. And now in the liver, this cholesterol is formed, and this cholesterol it gets converted to from the chylomicron remnant. This cholesterol is formed, and this cholesterol is taken up in the liver. The VLDL is released from the cholesterol is formed, and the LDL is formed. LDL gets converted to VLDL. LDL is taken up by the lipoprotein, low density lipoprotein receptor, and it forms the cholesterol. And from the cholesterol, the VLDL is formed. And this VLDL is broken down by lipoprotein lipase to fatty acids and IDL. And this IDL is again taken up by the liver, or it is converted to LDL, and this LDL is again taken up by the liver, and or it attaches to the LDL receptor in the body cells, which forms the cholesterol, which gets converted to HDL. HDL transfers cholesterol for disposal. This is the good density lipoprotein, high density lipoprotein. It will transfer cholesterol for disposal. Now, this is the exogenous and endogenous pathway. In the exogenous, bile acids and cholesterols. In the dietary lipids, in the small intestine, bile acids and cholesterol, they form the chylomicrons, which have ApoC, ApoE, and ApoB40. And on the chylomicron lipoprotein lipase, it forms free fatty acids, which get stored in muscles and adipose tissue. And the other form is chylomicron remnant, which is taken up by the LDL receptor, and LDL is taken up by the liver. And from the liver, VLDL is secreted, and it gets converted by the lipoprotein lipase in the capillaries to free fatty acids and IDL. And IDL is again taken up by the liver, or it gets converted to LDL, and it is taken up by the peripheral tissues like adipose and muscle tissue. And this is the endogenous pathway of the liver. These are the two pathways by which the metabolism of the lipids takes place in the body. Now, these are the diagrams showing the action of various drugs, that is anti-hyperlipidemic drugs, how they act. First of all, statins like atorvastatin, pravastatin, rosuvastatin, lovastatin, these drugs, they inhibit the HMG-CoA reductase enzyme, which is the rate-limiting enzyme in the synthesis of the cholesterol. This is the HMG-CoA enzyme is there. Cholesterol is formed from the mevalonic acid to which the cholesterol is formed. And this rate limiting enzyme, it will lead to decreased synthesis of the cholesterol. Statins, resins, and fibrates increase the uptake. Now these resins are bile acid binding resins. Resins, these act in the small intestine, in the from the gallbladder. Uh, from the gallbladder, the bile acids get combined with the these resins, and they get excreted out. In the normal person, the bile acids get combined with this fatty substances, and they get absorbed. These bile acids get combined with the cholesterol and gets absorbed from the intestine. But when resins are given, bile acids combined with these resins in the bile duct in the gallbladder, and these get excreted, leading to reduced formation of bile acids, and thus more bile acids will be produced, will be used to form the cholesterol. So bile acids reduce, and cholesterol it gets increased, or its cholesterol formation decreases because more bile acids are used for the formation of the cholesterol, and thus the leading to lowering of the LDL levels and lowering of the VLDL levels. Fibrates are lipoprotein lipase inhibitor enhancers. They enhance the lipoprotein lipase, so they convert the chylomicrons and LDL into free fatty acids, and chylomicron laminar into free fatty acids and VLDL and LDL. And this LDL is uptaken by the various tissues and by the liver, and it is again leads to reduction of the cholesterol in the body. Ezetimibe is the drug which reduces the absorption of cholesterol from the intestine to the blood circulation by inhibiting the Niemann-Pick like cholesterol one transporter. So intestine it excretes the cholesterol outside. Fecal excretion takes place, and no absorption of the cholesterol from the intestine into the blood circulation takes place. This is how the mechanism of action of various drugs takes place. Now, hyperlipidemia is the it is the development of atherosclerosis and coronary artery disease. It can be of two types: genetic, which is primary, and secondary, which can be due to diabetes mellitus, or alcoholism, or nephrotic syndrome, or chronic renal failure, hypertension, or administration of any drug can lead to hyperlipidemia. Management is to lower the plasma lipids is one approach. Usually there can be dietary management, and other modifiable cardiovascular risk factors are also should be corrected. Several drugs, they decrease the LDL cholesterol levels and increase the HDL levels. These are the drugs: HMG-CoA reductase inhibitors, statins like atorvastatin, simvastatin, lovastatin, pravastatin, fluvastatin, rosuvastatin, bile acid binding resins, cholestyramine, cholestyramine, polyvicelum, and the inhibitors of intestinal absorption of the cholesterol, that is ezetimibe is the drug which inhibits the Niemann-Pick cholesterol 1 like 1 protein. Activators of lipoprotein lipase are the fibrates. These are gemfibrozil, benzafibrate, fenofibrate, ciprofibrate. Inhibitors of the VLDL secretion and lipolysis. Inhibitors of lipolysis is niacin or nicotinic acid. Newer drugs such as cholesterol ester, triglyceride transfer protein inhibitors are NRC, trapib, and torcetrapib. Now, HMG co-reductors, these are the rate limiting step in cholesterol synthesis inhibitors by these enzymes. and they decreases the lipoprotein and low density lipoprotein levels, and they decrease the triglyceride levels, and they decrease the cholesterol levels in the body. The side effects are there can be hepatotoxicity, or there can be myositis can occur, rhabdomyolysis can occur. Other things are increases the uh, fasting plasma glucose levels, increases the fasting plasma glucose levels, which can lead to hyperglycemia. They increase creatine phosphokinase levels, then they can cause headache, joint pain, and rash. This is how the step of the uh, cholesterol takes place. The HMG-CoA gets converted to mevalonic acid and by the enzyme HMG-CoA reductase. And these HMG-CoA reductase inhibitor will inhibit this step, and thus no mevalonic acid and cholesterol will be formed. So decreased concentration of cholesterol in the cells. Then lower intracellular cholesterol will stimulate the synthesis of more low density lipoproteins on the surface of the liver. Low density lipoprotein receptors will be formed on the surface of the liver. Increased number of low density lipoprotein receptors will promote the intake of LDL from the blood into the liver, and there is also low intracellular cholesterol will decrease the secretion of VLDL. And this low intracellular cholesterol, it will also decrease the secretion of the VLDL in the blood circulation. These are the various drugs: statins, fluvastatin, pravastatin, rosuvastatin, with their pharmacokinetics given. And this rosuvastatin is the maximum HDL increasing capacity is of the rosuvastatin. It is the longest statin, and these are the inactive the pro drug is a lovastatin and simvastatin. Patent is the most potent, and the latest is the pitavastatin. And the atorvastatin is known to have the antioxidant property. Now, lovastatin, which is lipophilic and given in precursor form, lactone absorption is incomplete, and first pass metabolism is extensive. It has the extensive first pass metabolism. Simvastatin is more efficacious and twice potent than the lovastatin. It is also lipophilic and given in lactone precursor form. It is also given in lactone precursor form. It is lipophilic and it is more potent than the lovastatin. Pravastatin, it is the hydrophilic drug and given in active form. So it causes decrease in plasma fibrinogen level. Atorvastatin is having the good LDL cholesterol lowering capacity or increasing HDL capacity. It has additional antioxidant property, and this is longer acting. Once a daily dose is sufficient for the intake of for the action of the atorvastatin, and it is the newer statin. Rosuvastatin is also most potent and latest statin. Its half-life is also longer, 18 to 24 hours, and it has maximum HDL level increasing capacity as compared to other statins. And pitavastatin, which is latest and most potent statin, and when it is combined with fibrates like gemfibrozil, it causes myalgia, myositis can occur, so which leads to a more increased side effect because of reduced clearance, so it is avoided. These are the side effects I've already told you: headaches, sleep disturbances, rise in serum transaminases, so it can lead, it leads to hepatotoxicity, and muscle tenderness, rise in creatine phosphokinase levels, myopathy. 1 in 1,000 is the only serious adverse effect. It is more when given along with nicotinic and gemfibrozil and CYP3A4 inhibitors like ketoconazole. Means when it is given with niacin or nicotinic acid or fibrates, the myalgia or myopathy is more. Fenofibrate is safe for combining with statins. Statins should be avoided in pregnant women. Contraindications are pregnancy, lactation in children, and active liver disease, because it also increases the plasma transaminases level. Now, pleiotropic effects can be known by the name itself. Pleo It is plaque stabilization. PEL is for the plaque stabilization. E is for the decreasing endothelial dysfunction. I is for decreasing inflammation. Uh, and O is for having antioxidant property, and tropic is for anti-thrombotic action, which is having anti-thrombotic action. This is the summary of the pleiotropic effects of statins. Anti-thrombotic action is reduced to coagulation, increase endothelial progenitor cells, endothelial dysfunction will be inhibited. There will be also decreased effects of collagen, matrix metalloproteinases will be decreased, so there is no fibrosis, collagen formation is not there, and decrease inflammation, decrease immunomodulation, decrease macrophages, decrease endothelin, and also AT1 receptor action is reduced. So vascular smooth muscle proliferation is also reduced, and there is reactive oxygen species will be reduced, and there is nitric oxide vasodilatory action is increased, and platelet activation is decreased. These are the pleiotropic effects of these statins. Fibrates are that which bind to the proximal proliferator activator receptor alpha, and they activate the lipoprotein lipase, and thus chylomicrons and VLDL gets converted to IDL and chylomicron rapinins, and these get taken by the liver. So thus decreases the levels of LDL, VLDL, and HDL. HDL increases. VLDL and triglyceride levels decreases in the body, and decrease the release of fatty acids from the adipose tissue also. And this clinical uses in the elevated triglyceride and chylomicron remnants, we can give this drug fibrates, and its side effects are GI upset, dyspepsia, cholelithiasis, myositis, and hepatitis. And drug interaction is they increase the levels of warfarin and oral hypoglycemic drugs in the body. So there will be bleeding and hypoglycemic effects, increased uh, uh, in these side effects will be seen. Now, this is how the mechanism of the action of lipids takes place by the fibrates. Fibrates increase expression of the proteins in yellow. That is ApoA1, ApoA2, and ABCA1 gets increased. So, leading to increased HDL levels. And ApoC2, C3 is decreased. Triglyceride is decreased. Free fatty acid is decreased. So, decrease in VLDL levels, and the lipoprotein lipase levels increases. So, LDL levels also get reduced. So increase HDL production, decrease in VLDL production, and increased VLDL clearance. VLDL clearance will increase, and LDL particles will decrease and increase the particle size. This is the how the mechanism of action on lipids takes place. Basically, they activate the lipoprotein lipase, so free fatty acids will be reduced, and this LDL and VLDL will be reduced. VLDL and chylomicron raminols will be reduced. They will form the LDL, and this LDL will also get reduced. Now, gem fibrosol, apart from main action, it causes suppression of hepatic synthesis of triglycerides. Additional action include decreasing level of clotting factor 7, phospholipid complex, and promotion of fibrinolysis. So it is having anti-atherosclerotic effect. It promotes the fibrinolysis and phospholipid complex, clotting factor. GI distress, eosinophilia, impotence, and blood visual are some of the side effects. And there can be myopathy, which is uncommon, and this is contraindicated in pregnancy. Used as it is used given before meals, because meals can decrease the absorption, food can decrease the absorption of the fibrates, and it is used to treat increased triglycerides, acute pancreatitis, and hypertriglyceridemia. Benzafibrate is another fibric acid derivative, an alternative to gemfibrozil. It has the greater LDL lowering action than gemfibrozil. Adverse effects are less GA upset, rashes, action of anticoagulant is increased. Combination with statin not found to increase the risk of rhabdomyolysis. Means it does not increase the risk of bezafibrate, does not increase the risk of rhabdomyolysis or myopathy. Phenofibrate, it is again the second generation product of fibric acid derivative. Apart from decreasing triglycerides, it also decreases LDL, increase HDL levels, longer half-life, hence once given OD, once daily dose is effective. Polylithiasis rhabdomyolysis is rare, won't potentiate the statin-induced myopathy. Polylithiasis and rhabdomyolysis is rare. Interactions are that increased risk of myopathy when combined with statins by phenofibrate, and it displaces drugs from the plasma proteins, means they increase the free drug levels in the unbound blood levels in the blood of the warfarin and hypoglycemic agents. So there will be more bleeding tendencies will be there, and hypoglycemia can occur with the anti-diabetic drugs. Contraindications are patients with impaired renal functions, pregnant or nursing women, pre-existing gallbladder disease. Now, next is nicotinic acid, niacin, or vitamin B3, which is the lipolysis or triglyceride synthesis inhibitor. It inhibits the lipolysis in adipose tissue, so it decreases the levels of free fatty acids, thus decreasing the levels of triglycerides, thus decreasing the levels of the VLDL and LDL. So VLDL is reduced, LDL is reduced, and increase in HDL cholesterol is there. And these are inexpensive, means these are cheap drugs. Decrease the catabolism of the APO1, hence increase the HDL levels, boost secretion of tissue plasminogen activator, and hence lower plasma fibrinogen. It also lowers the plasma fibrinogen. Uses it is used in hyperlipidemia and patients with increased risk of CHD, that is coronary heart disease. Adverse effects are due to release of the prostaglandins, that is PGD2. These are responsible for releasing prostaglandins in the body due to action of PGD2, and they cause flushing and pruritus. And this can be reduced by giving the laropiprin, or it can be reduced by giving aspirin, low dose aspirin, which is the prostaglandin synthesis inhibitor. So in first 14 days, it can be given, and this flushing and pruritus can be controlled. Laropiprin is another PGD2 antagonist drug, and it is given orally. Cholestasis can be there. Hyperuricemia, increased levels of uric acid, so gout can occur, and hepatic dysfunction, hepatotoxicity can occur with niacin. This is the mechanism of action. That is, it inhibits the triglyceride synthesis. Lipolysis is inhibited. Lipolysis inhibitor means these free fatty acids will reduce in the hepatocytes, reduce triglyceride synthesis, reduce VLDL secretion, and this serum VLDL results in reduced lipolysis to LDL. Then reduce LDL, increase HDL, reduce clearance, not reduce synthesis. HDL will increase because of reduced clearance. Wide spectrum anti-hyperlipidemic drug, most effective in reducing triglyceride levels, to be taken just after food to minimize flushing and itching, because food will decrease the absorption, and it should be given after food to minimize flushing and pruritus. The cholesterol absorption inhibitors, these are the azithromycin. It inhibits the luminal cholesterol uptake by inhibiting the transport protein, that is Niemann-Pick1, like cholesterol 1 like 1 transporter is present in the intestinal mucosa, which increases the uptake of cholesterol from the intestine into the blood, and this luminal cholesterol uptake is inhibited by the azithromycin, which is the cholesterol absorption inhibitor, and thus this will lead to decrease in levels of cholesterol, decrease in LDL. Side effects will be diarrhea, abdominal pain, angioedema. This is how the azithromycin acts in the duodenum, in the jejunum, in the ileum. Azithromycin will block the uptake of the cholesterol, decrease chylomicrons, and remnants will be decreased. So decrease uptake of the chylomicron or the LDL into the liver. So decrease LDL, decrease VLDL. This is the mechanism of action of ezetimibe, which is the cholesterol absorption inhibitor. Nimen pick like one, cholesterol 1 like one transporter protein inhibitor. Reduces both dietary and biliary cholesterol. Half-life is 22 hours. Long half-life permits once daily dosing and may improve the compliance. Because once daily dosing, so patient does not stop taking the drug. Only once a day they have to take the drug. So it is very effective. Now, bile acid lessons are that in the intestine we have the enterohepatic cycling, means the bile acids combined with the food particles such as fat, fatty acids, fatty soluble substances, and the bile acids they combine from the gallbladder. This bile acids and the drug it reaches the intestine, and from the intestine the drug particles, the fat gets absorbed. And when and again the bile acids get reaches in the gallbladder back without after freeing the cholesterol containing substances, the fatty substances in the circulation. This is the enterohepatic cycling. When the bile acids are given with the resins, means when resins are given, they will combine with bile acids, and this bile acid resins will form the insoluble complex, and they will not they will be secreted in the feces, and this will lead to reduced presence of the bile acids in the body. So the more bile acids will be used up to more cholesterol will be used up to form bile acids, leading to decreased levels of cholesterol. Decreased levels of cholesterol will lead to decreased levels of LDL, increased level of HDL, and decreased levels of triglycerides. Now, this is bind intestinal bile acids, these resins, decreased bile acid absorption, increased hepatic conversion of cholesterol to bile acids, and thus LDL receptors will increase on hepatocytes, which will lead to increase uptake of the LDL from the blood into the liver, leading to decreased LDL in the circulation and increased HDL and decreased triglycerides. These are constipation side effects, increased gallstone formations, and GI upset, liver function test abnormalities can be there, myalgias can be there, reduced absorption of drugs, and fat soluble vitamins from the intestine. This cholestyramine and cholecybellum form an insoluble complex with bile acids and salts, preventing the reabsorption from the intestine. These are the drugs used in the hypertriglyceridemia with niacin, pruritus in patients with cholestasis, and digitalis toxicity. These are the drugs of choice for pruritus and in patients with cholestasis and digitalis toxicity. And this cholestyramine and cholesterol are having the very unpalatable taste is there. Its taste is not good. So they are taken with water or juice, taken with meals. And colbicelum is given 6 tablets per day. Adverse effects are constipation, hemorrhoids, GIT distress, absorption of fat soluble vitamins, and folic acid is impaired. Fat soluble vitamins absorption and folic acid is impaired. Drug interactions are due to risk of decreased absorption of these drugs. There will be decreased absorption of these drugs. So reduced absorption will lead to digitalis toxicity. Estrogens and progesterones will lead to contraceptive failure or hypoglycemia by oral diabetic drugs. These are decreased absorption of these drugs will be there. Contraindications are complete biliary obstruction because bile is not secreted into the intestine, and chronic constipation and severe hypertriglyceridemia are the contraindications. CETP is the cholesterol ester triglyceride transfer protein inhibitors. These torcetrapib and anacetrapib are banned. Dalcetrapib in the clinical trials, anacetrapib increases HDL levels by 129%. Obesity is in the phase 2 trials, results reported in 2015. Now, these are the cholesterol ester transfer protein. It facilitates the cholesterol esters from HDLC, that is HDL cholesterol, to LDL cholesterol and VLDL cholesterol during reverse cholesterol transport. And these are inhibitors of this protein. The CETB inhibitors will markedly raise the HDL cholesterol levels and lower the LDL levels, because the cholesterol esters will not be converted to triglycerides in the HDL, in the LDL and the VLDL, and these HDL cholesterol levels will increase. Hence, the LDL cholesterol levels will decrease, VLDL will decrease. Cholesterol esters will remain with the HDL, and thus reverse cholesterol transport will not take place. And this is the cholesterol ester transfer protein inhibitors function. Now, combination drug therapy can be given to reduce the lipid levels in the body. Statins, as these are HMG-CoA reductase inhibitors, and niacin are lipolysis inhibitors. So they will reduce the levels of cholesterol in the body, the statins, and niacin will reduce the levels of free fatty acids, reduce triglyceride synthesis, and in turn reduce LDL and VLDL, and increase the HDL levels. So this combination can be used to have the additive effect of the antihyperlipidemic drugs. Statins, again, these are the cholesterol synthesis inhibitors, HMG-CoA reductase inhibitors, and these ezetimibe is the cholesterol ester, cholesterol absorption inhibitor. So it will inhibit the absorption of cholesterol from the intestine into the blood. So again, levels of cholesterol will reduce. They will have the additive effect. Statins, again, these are cholesterol HMG co-reductase inhibitor, cholesterol synthesis inhibitor. Fibrates, they will activate the proliferated. These are the peroxisomal proliferated activator receptor, alpha receptor activating, leading to enhanced the lipoprotein lipase activity, leading to decreased production of free fatty acids, and increased production of the LDL, and VLDL and the LDL will reduce the levels. Bile acid binding resins will again reduce the levels of cholesterol, because more bile acid will be converted to cholesterol, because bile acid will be excreted while combining with the resins. So cholesterol synthesis will be reduced. So cholesterol levels will be reduced. They will be converted to bile acids. Fibrates, the lipoprotein lipase inhibitors, which converts the uh, chylomicron remnants into the chylomicron into the LDL and VLDL, which will reduce the levels of LDL and VLDL, with niacin, which is the lipolysis inhibitor. So reduce triglyceride levels, reduce free fatty acid levels, reduce LDL and VLDL levels. Resins, again, and statins, they also HMG-CoA reductase inhibitor. So they will reduce the levels of cholesterol. Additive effect will be there. Resins, statins, and niacin are again used to have a additive effect of reducing the levels of cholesterol, reducing the levels of low density lipoproteins and very low density lipoproteins, and increasing the levels of HDL. So LDL effect is more on the by the statins. Most is on by the statins, followed by bile acid sequestrants, which converts the cholesterol into bile acids. So cholesterol LDL will be reduced. Then niacin, then fibrates and cholesterol absorption inhibitor. HDL will be maximum increase of the HDL will be niacin, then fibrates, then HMG-CoA reductase, then bile acid sequestrants, and then cholesterol absorption inhibitor. And effect on triglycerides is maximum with the fibrates, and triglycerides will be reduced because triglycerides get converted to LDL and VLDL. And minimal is by the cholesterol absorption inhibitor, minimum triglyceride reduced, and by the bile acid sequestrants. And niacin, it also has the triglyceride lowering capacity. Thank you. That's all for my class on antihyperlipidemic agents. Hope you understood. Happy learning. Thank you. If you understood, kindly subscribe to my channel.